Let's turn to the patient with an EGFR mutation who has brain metastases, and specifically sub-centimeter and asymptomatic, but we get a routine MRI and find that. Historically, we would reflexively reach out to our radiation oncologist either for whole brain previously and increasingly now stereotactic radiosurgery. But we now have osimertinib with very good CNS activity. Are you comfortable deferring on radiation for these patients and seeing what systemic therapy can do first?
That's the beauty of having osimertinib. I think if they're asymptomatic, I'm comfortable following the patient is compliant, the radiation oncologist feels comfortable, there's no surrounding edema. I'm very comfortable using osimertinib with close MRI follow-up.
Mm-hmm.
Yeah, I do the same.
Okay.
In fact, I'm so comfortable because my radiation oncologists are comfortable with that, and they're the ones who usually get nervous. But I think as a team, we've decided that for the small asymptomatic patient population, going with the systemic therapy is just as reasonable. So that's what we've done.
We also have similar data with ALK inhibitors, and I think we have the similar degree of comfort. What about for patients without a driver mutation? Are you comfortable with giving immunotherapy or chemoimmunotherapy a try with this, or is it really just something where we have to have targeted therapies with known intracranial activity?
I've been a little bit more comfortable with really small asymptomatic brain metastases in the IO world. There is some data generated, phase 2 studies suggesting that in a patient population with non-small cell lung cancer, single agent IO can have activity. So again, as long as we have close follow-up of these patients with small asymptomatic brain metastases, I've been comfortable starting with chemo IO and observing. Obviously, the size and all of that sort of becomes a discussion between the radiation oncologist, us, and the patient. There's a lot of edema and all that, then I feel a little bit less comfortable not treating. But as I said, the really small sub-centimeter asymptomatic ones, I'm willing to start with the systemic therapy.
I'm more comfortable starting systemic therapy, but I'm not as comfortable just leaving it be. I think we are more comfortable sandwiching, like a stereotactic radiosurgery approach. If I'm doing just IO alone or chemo IO in these non-driver mutation patients. But I agree. I think more and more our radiation oncologists are also feeling comfortable with the idea of beginning systemic therapy first.
And close monitoring.
Yeah, very close monitoring. Yeah, absolutely.
Many patients with an EGFR mutation will end up getting chemo without the concurrent, Many patients with an EGFR mutation will end up getting chemo, but not with a concurrent immunotherapy. What would you say is the role, if any, for immunotherapy in these patients? Would you give it as a single agent? If so, when? Or are you so pessimistic about the activity of immunotherapy in these patients that you would not pursue it?
I probably wouldn't pursue single agent IO off of a trial or anything like that for this particular patient population, because I think the bulk of the data still suggests, and most of it is retrospective, but bulk of the data suggests that the single agent IO is probably not as an effective treatment strategy for the EGFR or molecularly driven tumors, or a lot of them at this point. If I have a trial that uses a combination of different immunotherapy approaches, then I think I'm a little bit more inclined to do it, or a trial with IO plus a VEGF inhibitor, I'm more inclined to do it. But to me, as a standard of care, if they're progressing on the TKI and I don't have any other options, then I think, again, platinum doublet chemo or the Empower 150 is the way I would rather go with this patient population.
Charo?
I don't think it's a matter of being pessimistic. I think it's just a matter of being realistic with what the data are telling us. I think it's very clear that immunotherapy over a TKI approach in an EGFR mutant population is a bad idea, as demonstrated by the phase 2 trial that was published in JTO earlier this year, where patients with high PD-L1 expression went on to receive pembrolizumab first with an EGFR mutation, and they had 0 response rate and actually fatal pneumonitis. So I would be very cautious to offer immunotherapy as a single agent, even if PD-L1 is high in these patients. And I often talk to patients, and patients struggle with why we're not offering pembrolizumab when they see it on TV, when they've already seen that their PD-L1 result is 60%, but it's a matter of educating them that chemotherapy may indeed be the better way to go.
I think that's a great point, that I'm specifically thinking in terms of in the relapsed and progressing setting. My personal approach is that I'm less optimistic about how well it's going to work, but I want to give every patient the benefit of the doubt and the opportunity to benefit, even if it's going to be a later line option. Then it wouldn't necessarily be my routine second line choice. That may be a group where I would be really more inclined to do, docetaxel ramucirumab or something before that. So I wouldn't exclude these patients. But your point about underscoring that these patients with driver mutations should not get immunotherapy up front, even if they have high PD-L1, don't take the bait. It doesn't mean the same thing in a patient with an activating EGFR mutation or an ALK rearrangement, and could poison the well in terms of toxicities with TKIs later. So it's a great point, and so we'll need to learn more, and we will. I mean, fortunately, EGFR mutation positive patients are being studied much more for the potential efficacy and combinations for immunotherapy.